Hello, my name is Cindy Hernandez, and I'm here to present to you our research presentation based on vitamin D status and rates of cognitive decline in a multi-ethnic cohort of older adults with my two presentation partners, Daira Magdalena and Angelita Urejo Villalba. Introduction. So what is being studied in this article and why? The authors of this article aim to understand the effects of low levels of vitamin D on cognitive function and how this might possibly have various neurological, psychological effects on human health. By focusing on participants who are ethnically diverse older adults and may or may not be able to associate with some level of mental and cognitive decline, it could help the authors identify any correlation or relationship between low levels of vitamin D intake. The question is, does vitamin D insufficiency or deficiency exacerbate their symptoms in various cognitive domains, or is there no association involved at all? So what characterizes vitamin D deficiency and insufficiency? Per the authors of this article, vitamin D is denoted as 125 dihydroxy vitamin D, which is an active form of the vitamin. A serum 25-hydroxy vitamin D 25-OHD level that falls below 20 nanograms per milliliter is concerning. Levels that fall below 12 nanograms per milliliter are considered deficient. Levels that fall between 12 nanograms per milliliter and 20 nanograms per milliliter are considered insufficient. Combined deficiency and insufficiency among the general adult population is about 42% in the United States. There is a higher prevalence of this among Hispanics, which is 69%, and the African American community, which is 82%. Both the VIT-D receptors and the enzymes that converts the VIT-D to the active form are expressed in all human organs, including the brain. VIT-D is now recognized as a vital component for all organ systems health. The research objectives. So what the research objective of the article was, it was to examine the effect of VIT-D deficiency and insufficiency towards cognitive functions in various domains in a cohort of ethnically diverse older adults. This can determine if there's a relationship between low levels of vitamin D and cognitive decline. Investigate how different categories of vitamin D status correlate with cognitive performance over time, particularly focusing on episodic memory, semantic memory, executive function, and visual spatial ability. The methods. So the participant sample, which was a sample size of 382 participants in the University of California at Davis Alzheimer's Disease Center Longitudinal Community Diverse Study, 72.2 of participants were recruited via community-based outreach to enhance racial and ethnic diversity to be more inclusive on a broad range of cognitive dysfunction spectrums. 27.8 were recruited via memory clinic referrals, and the overall sample included 113 African American participants, 96 Hispanic participants, 158 white participants, and 50 participants from other racial and ethnic groups, which consisted 6 Filipinos, 6 Asians, and 3 others. No participant was institutionalized during the observational period of this study. The inclusion criteria of the study included 60 years of age, older than 60 years of age, ability to speak English or Spanish, being community dwelling, and the exclusion criteria was physical and psychosocial issues that would prevent longitudinal assessments such as cancer with poor prognosis or major psychiatric disorders like schizophrenia and major bipolar disorders. Also excluded was substance abuse or dependency with 5 years. The clinical evaluations. All participants received a multidisciplinary diagnostic evaluation through the program at baseline with approximate annual follow-ups. Evaluations consisted of detailed medical history, neurological examinations, and neuropsychological testing. Spanish-speaking participants were evaluated by a physician fluent in Spanish. Individuals close to the participants were also interviewed about the level of independent functioning the participant had. BMI was determined from baseline height and weight. Diagnostic tests that were made were evaluation using clinical dementia ratings, neuroimaging, laboratory work, and neuropsychological testing using uniform data set. So the neuropsychological outcome measures were primary cognitive outcome measures were derived from Spanish and English neuropsychological assessment scales for measures four cognitive domains. The episodic memory were used for wordless learning, semantic memory, object naming and picture association tasks, visual perception, assessed ability to perceive and reproduce spatial relationships, and executive functions, use, ladder fluency, category fluency, and working memory tasks. How obtaining the blood and VIT-D levels occurred was non-fasting blood samples were collected by standard venipuncture. Serum was obtained via centrifugation and stored at -degrees Celsius until analysis. The 25 OHD serum concentrations were determined by competitive immunoassay. Participants were categorized into four groups based on current guidelines. Deficiency less than 12 nanograms per milliliter, insufficient 12 to less than 20 nanograms per milliliter, adequate was 20 to less than 50 nanograms per milliliter, and high was greater than or equal to 50 nanograms per milliliter. The statistical analysis of the methodology, other methods used in this research study was analysis of variance, were used to compare baselines 25 OHD levels or VIT-D status by season of blood draw, cognitive diagnosis, and race ethnicity for a full cohort of participants. Also, post hoc pairwise comparisons were utilized if an overall differences by group was detected. Linear regression model to assess the association between VIT-D levels or status and baseline cognitive functions. The repeated measure models were used to assess associations between VIT-D and annualized change in cognitive since baseline in the substance was longitudinal assessment. Also, the adjusted models of sex, age, race, and ethnicity. And the level of significance, the p-value of leads, then 0.05 was considered to be statistically significant. The results.
Hi, my name is Daira Magdalena, and I'll be taking over the results portion of our presentation. So the first part where we focused is the prevalence in vitamin D deficiency and insufficiency. Among the 382 participants, 26.2% were categorized as VIT-D deficient, so that meant that they had a level of 12 nanograms per milliliter, and a 35.1% as insufficient, which is a level between 12 to less than 20 nanograms per milliliter. The average 25 OHD level was resulted at 19.2 nanograms per milliliter. The cognitive status within the participants were 17.5% that had dementia, 32.7% had mild cognitive impairment, 49.5% were cognitively normal. The 25 OHD level was higher within white participants, 21.7 nanograms per milliliter, than among African American participants with a level of 17.9 nanograms per milliliter, and Hispanic participants at 17.2 nanograms per milliliter. Participants diagnosed with dementia had lower vitamin D levels compared to those with a mild or normal cognitive state. Follow-ups were made an average of 4.8 years, so close to 5 years. The next section that we focused on was the rates of cognitive decline. VIT-D deficient patients experience accelerated declines in episodic memory and executive function compared to those with adequate vitamin D status. The rates of decline over a 5-year follow-up showed VIT-D deficient individuals decline 0.30 SD, which is standard deviation, and this was equivalent to 0.06 SD per year in episodic memory, and 0.46 SD, which it's equivalent to 0.08 SD per year in executive function compared to VIT-D adequate patients with an episodic memory decline of 0.10 SD, which also is similar to 0.02 SD per year, and 0.20 SD which is 0.04 SD per year decline of executive function. The first table that we will be discussing and reviewing is Table 1 from our research. Table 1 goes over the baseline characteristics of the study cohort. The mean, or the SD age, was around 75.7 years, and 61.8% were women. The cohort was racially and ethnically diverse, with African American and Hispanic individuals accounting for approximately 50.7%, and about 90% of Hispanic participants in the study were of North, Central, or South American ancestry, but most commonly Mexico. The mean educational level was equivalent to a high school graduate as well, but on average, most participants were overweight with a mean BMI greater than 25 and had two vascular risk factors, which included hypertension and hypercholesterolemia. The conclusivity of the data had gathered 382 participants of the average age of 75.5 years old, being distributed in several different categories such as age, gender, BMI, education, cognitive diagnosis, vascular risk, and vitamin D levels. The study highlights significant racial and ethnic differences in cognitive status, body composition, and vitamin D levels. White participants had the highest levels of vitamin D and the lowest rates of deficiency, while African American and Hispanic participants had notably lower vitamin D levels and higher deficiency rates. These findings suggest that race and ethnicity plays an important role in both health outcomes and the need for targeted interventions in managing vitamin D deficiency. Next, Table 2 in the research showed the baseline mean of 25-OHD level was lower in individuals with dementia compared to cognitively normal individuals and those with mild cognitive impairment, or MCI. VIT-D deficiency and insufficiency were higher in the dementia group with 35.8% and 40.3% for both, compared with the two other groups. However, these differences did not reach statistical significance. The results from this table do not seem to reflect any differences in nutrition status, given that the mean BMI for the participants with dementia did not differ from two other groups. And there was also no interaction between cognitive status, BMI, race, and ethnicity. Next, in Table 3, the vitamin D levels and the cognitive function scores were assessed in a sample of individuals with the following cognitive domains. For episodic memory, the N value was 325, semantic memory had an N value of 324, visual spatial ability had an N value of 288, and executive function an N value of 329. The log serum 25 OHD level showed significant lower cognitive decline. Episodic memory had a p-value of 0.01, semantic memory had a p-value of 0.04, and executive function had a p-value of 0.001. For every 50% reduction in the 25 OHD concentration, the rate of cognitive decline increased as follows. Episodic memory 0.035 SD per year, semantic memory 0.028 SD per year, and executive function 0.042 SD per year.
Hi there, my name is Angelita Araujo Villalba, and I will be taking over this third portion and final portion of our presentation. So we will go over Table 4, and our results indicate that we have associations between vitamin D status and longitudinal change in cognitive function. Associations between vitamin D and change in cognitive domain scores are shown in this table. A 1-unit increase in natural log 25-OHD concentration was associated with significantly slower rates of decline in episodic memory, semantic memory, and executive function. Rates of cognitive decline were greater in the vitamin D deficient and vitamin D insufficient individuals than those with adequate status for episodic memory and executive function. During 5 years follow-up, vitamin D deficient individuals declined 0.30 standard deviations in episodic memory and 0.46 standard deviations in executive function, while those with a normal 25-OHD status declined 0.10 standard deviations in episodic memory and 0.20 standard deviations in executive function. Differences in these rates of decline for semantic memory and visuospatial ability were not significant. Figure A through C goes through the trajectories of cognitive function domains over time by baseline vitamin D status. These graphs show the trajectories that certain vitamin D patients showed when comparing episodic memory, semantic memory, visuospatial ability, and executive function. The differences in these vitamin D quantities have played a significant role in the vitamin D deficient group, showing a rapid decline, reaching extremely low levels in all areas compared to their vitamin D adequate counterparts. Each graph denotes a downward negative slope, and all slopes of decline differed from adequate scores to the insufficient and deficient scores. The least greatest scores were in the category of semantic memory and visuospatial ability. This shows that the lack of vitamin D has some severe signs of cognitive decline for individuals with declines as fast as 50% in 5 years. Final conclusions. Our final conclusions on the article are as follows. There were lower levels of vitamin D that were associated with accelerated decline in areas of cognitive function in ethnically diverse older adults who displayed a higher prevalence of vitamin D deficiency or insufficiency. African American and Hispanic individuals are more likely to have vitamin D deficiency or insufficiency compared to the rest of the population. Aside from race and ethnicity, low levels of vitamin D are associated with significantly faster rates in cognitive decline in both episodic memory and executive function performance. This can correspond to an elevated and higher associated risk for incidence of Alzheimer's disease dementia. Vitamin D insufficiency is medically correctable, and low levels can be mitigated by ensuring proper vitamin D exposure and consumption. Scientists are yet to determine if vitamin D supplementation can help slow cognitive decline processes in all individuals. Conclusions indicate that the authors of the study confirm previous cross-sectional findings that show significant difference in vitamin D levels among individuals with normal cognition, mild cognitive impairment, and dementia. Discussions. The discussions on the article are as follows. We had questions regarding the experimental data and results, and these go a little bit in depth on really what our concerns were with the experimental data and the results. Our first question was, what would be the result of performing an experiment on individuals who are younger than 60 years of age and or not associated with a prior history of severe cognitive decline with an illness such as Alzheimer's and dementia, as well as mild cognitive impairment? Well, we could definitely see how low levels of vitamin D affect populations of individuals who aren't associated with cognitive illness. We could also see the rate at which young and healthy individuals could have a faster cognitive decline compared to older participants. Our second question addresses how can we know that this study was able to differentiate between low levels of vitamin D causing these faster rates of decline in both episodic memory and executive function, and the participants having faster rates of decline because they are already afflicted with a cognitive illness and the illness itself isn't causing the cognitive decline? Well, we can perform an experiment on younger, healthier adults to determine if there is still a strong relationship between low levels of vitamin D and cognitive function decline. Now, what are the implications on the research findings? We now know that there's an association between cognitive decline in older adults and low levels of vitamin D. So how can we mitigate this? How can hypovitaminosis D be prevented by taking supplements? We definitely know that research is still being performed and it's still underway. As of this moment, we are unsure. What supplements are most effective? Well, this is highly subjective, given that the FDA does not regulate most supplements, and this can provide inaccurate information on the quote best supplements for vitamin D health. Additionally, taking supplements is a personal choice and is highly subjective. So, an individual person does need to make or set time aside to do their own research on what vitamins and supplements are best suited for themselves. Can this create a false illusion of medical interventions and solutions that may not actually help alleviate cognitive function decline in similar individuals to the participants? Well, this can possibly create a false sense of therapy or even a quote cure to those who suffer from mild cognitive impairment or even dementia. However, it is not to say that vitamin D does not help their symptoms and possibly slow the progression of their cognitive function decline. However, it is important to note that all of this research is still underway, and research related to supplements and how vitamin D can affect cognitive function decline is still very much being researched at this point, and there is no way to tell if vitamin D can actually help slow down the progression of cognitive function decline. What are the positive outcomes expected from this research and experimental data? Well, we can expect more individuals will find the information of vitamin D deficiency and insufficiency to be helpful when it comes to expanding their awareness on their cognitive health. We also now understand that vitamin D is a vital component of all organ systems, and it affects their physiological functions. Therefore, we can hope that the general population will find this information useful and use it for preventative healthcare purposes. Additionally, individuals who are currently afflicted with mild cognitive impairment or dementia can try their best to ensure they are receiving enough vitamin D levels for optimal health. This can, with the best intentions and hope, help their symptoms and overall health, as well as slowly delay the progression of their illness. These are our references. And thank you so much for watching this presentation. We hope you enjoyed it. Bye!